And due to the strong telehealth utilization or in specialist care, which is itself a product of hospitals networking within hospitals, across hospitals, more integrated provider networks have been able to confidently expand their use of digital working to outside hospitals and into primary care. And this was evidenced across all major healthcare providers that I visited. Even in a public healthcare system, that of San Francisco, which includes a major general hospital, more than 25 community primary care clinics, they face significant delays in accessing specialist services. And due to those delays, they started to offer an increasing range of telehealth services to the primary care physicians that see patients in order to reduce waiting times. So the GPs can take photos of skin lesions, send to dermatology departments, and that way close more than half of all cases, and thus also halving the waiting lists down to a month for the rest, originally being more than 2 months. And the 6-month waiting time for pulmonary function testing at a public hospital was tackled by using a video link from the community clinics to the specialist nurses who guide the local staff and patients on how to undertake the specialist tests correctly and how to interpret the results and therefore also treat the patients. Again, another integrated digitization journey in a public healthcare system. Now, finally, for the US, now in many ways, the healthcare system run by the federal US government for armed forces veterans is the closest really to a single national healthcare system the US has that resembles those normally afforded to whole populations in other countries. It is therefore the largest integrated healthcare system in the US, providing care through more than 1,000 facilities, including 170 medical centers within patient care, hospitals, let's call them, to over 9 million veterans enrolled. The VA was an early pioneer in the implementation of electronic health records and has continued to innovate on a large scale. They have moved fast and early to build telemedicine into their services, mainly because they serve patients who are spread across the country, and many are in rural areas. Again, as with all vertically integrated systems in the US, in the Veterans Affairs, Veterans Health Administration hospitals and healthcare system, their GPs are able to easily contact their specialist doctor counterparts, ask for advice via the single electronic health record system that they run, as well as receive advice via video during a clinic. So the epilogue, if you like, to the US is that, and it contrasts with the great examples I just described. Having said all this, worth to flag the following. The US healthcare system is so complex and has so many players, and that really affects any efficiency and value for money you can extract from such a complex system to the extent that it is estimated that $2 billion is spent annually just chasing and maintaining provider data, as they call it, i.e., knowing which doctor sees or can see which patients from which provider network and which insurer and which insurance plan and how much they charge for those patients versus other patients and when they see them. $2 billion wasted just to make sure that they can do things that, frankly, universal healthcare systems like the NHS perhaps don't need to. Having said that, I'll move to the New Zealand examples, a couple of really acclaimed examples of integrated care and digitization. So I'll start with Canterbury. In the 2000s, the Canterbury district introduced an integrated health and social care system, starting with using community-based rehabilitation to help avoid admissions, reduce length of stay. So the Canterbury District Health Board is deemed as the main, if not really only, exemplar of true integrated contracting in New Zealand by bringing together separate provider and purchaser budgets and how these are used, and in effect operating as a single budgetary pool. A lot has been written already about the success of the Canterbury District model of integrating care and the successes in reducing hospitalization, readmissions, and it has been regarded as a successful care system, which has moderated the rate of growth in hospital utilization by investing in services in the community instead. At the center of the integrated system in Canterbury is a clinical alliance. Its purpose to lead the improvement efforts of the health system through clinically focused service development. But what I want to add to this is the digital angle, which has been central to its success in the following ways. So for the diagnosis and treatment of more than 500 conditions, they follow shared online pathways across primary and hospital care, agreed by GPs and consultants of the clinical alliance I mentioned. Patient cases are very easily discussed online before referrals to specialist care. And actually, they've also created a shared electronic patient record for primary care, and admittedly a separate, but nonetheless, a full another electronic patient record for hospital care. These cover the whole of the district and indeed by now the whole of the South Islands. Yes, they are separate, but they are as comprehensive as they can be in their primary care and the hospital care worlds, if you like. And I will finish by giving another example, which is a different one of a bottom-up general practice transformation and improvement. So New Zealand is split into 20 primary health organizations. These are management layers above general practices, sort of like here in England, the primary care networks or a GP federation. If you like, a practice chain on steroids is the best I can do to describe them. Now, one of those 20 has excelled in becoming a not-for-profit partnership, which, yes, runs their member practices, but also offers a large range of digital services and solutions to practices, including their own telehealth solution for the practices to use. What have they achieved? Well, the local system manages, among other results, to reduce emergency department presentations for the over 65s by a third, ambulatory sensitive hospital admissions by a fifth. The reason for this success is that in 2010, they pioneered the New Zealand and created the New Zealand healthcare home model based on the US primary care medical home model. Now, where partner organizations have bought into the vision, district nurses are connected to the healthcare home GP practices, sharing patient information electronically and jointly planning care for those with complex needs. So I gave a lot of examples of how the integration journey is the one that has driven the good use of digital and vice versa. But I will move on to payments. So who pays for digital services and access to care? Who needs to pay? Who wants to pay? And I'll start actually, before I delve into the examples, by saying that financial drivers are at the epitome of incentives and levers for digitizing care. And they're a major collective of factors on how well the healthcare system manages to adopt digital innovation. Payments then translate into also how well, if you like, the NHS can replicate some overseas models. For example, does an overseas healthcare system offer universal care or not? Is additional, complementary, supplementary private insurance widespread? How much do people pay out of pocket to access care in those systems? These are all very important. And I will start with the US again and talk about independent telehealth care providers and their delivery via insurance or direct-to-consumer models. So, for example, the US on-demand telehealth GP market is and has been extremely lively, be it direct-to-consumer or as a benefit of private health insurance. And actually, overall, direct-to-consumer struggled to take off in its own right. This has meant that tech providers, telehealth providers have been diversifying to find the demand for their services and identify who would pay for those and why. The synergy that can be achieved in the US has led to a plethora of different models, such as a telehealth provider acquiring a remote monitoring and long-term conditions management company to offer a single comprehensive services across telehealth, remote monitoring, and long-term conditions management remotely. Another telehealth provider and an insurance company formed together a digital-only primary care plan as a low-cost way for employers and employees to access primary care, with patients also issued with standard medical devices to measure blood pressure and other vitals from home. And finally, a telehealth provider partnering again with a major insurer, but also with a mobile phone manufacturer to offer seamless access via the mobile phone's native health app, so long as, of course, you have the specific brand of phone and are insured with a specific insurer. The benefit is that one can therefore use the single app as a one-stop shop platform to track their health, well-being, lifestyle, integrate wearables, share data, and actually communicate with a healthcare provider and healthcare professionals through that one single app. It is impressive. I'll move to a different set of examples, similar but different, in Australian general practice and how telehealth is reimbursed there. Now, in the US examples, everyone and anyone would be paying for access one way or another. The Australian primary medical care model is different, and that presents different challenges in the uptake of telehealth. Unlike the UK, but like the US, in Australia, GPs are paid fully, if you like, as fee-for-service with no capitation. Now, the government does offer reimbursement of visits to the GP up to a level. Therefore, you end up with two types of general practice: fully reimbursed, where you see the GP effectively for free, and you get to pay a bit extra, but get a better experience and more time with your GP at an appointment. Either way, access to primary care is very good in Australia, driven by the fee-for-service model, whatever that may actually mean for overutilization of care. Until the pandemic, GPs wouldn't get paid by the government for telehealth appointments. The financial reason for this being that governments of healthcare systems where providers are paid via fee-for-service tend to be cautious of opening up reimbursement for a new care channel, such as online, if not well warranted that it will deliver a return on that additional spending and that it will not drive overutilization by creating and meeting additional demand, even if not necessary or optimized, actually, rather than address lack of capacity per se. What that really means is that the main market for telehealth in primary care in general practice in Australia was the on-demand, private, non-reimbursable telehealth. However, again, this hadn't been successful up until the pandemic. Why? The reason is that most people prefer to either get free, i.e. the reimbursed care, or pay extra, but for the more in-depth quality consultation, longer appointments, rather than just for any perceived convenience of the channel shift alone, of going online alone, which is interesting and says a lot about patient and consumer behavior. That actually takes us to a different example, but showcases the same, about patient portals for online access to key services and charging for those in New Zealand. So I will finish this section on payments by showcasing an example, still from the patient-facing digital primary care sphere. Now, New Zealand adopted patient portals, as they call them, through which GPs can provide to their patients with online access to a range of potential services, such as the ability to request repeat prescriptions, book appointments, access their record, messages to and from their practice. And yes, a few years ago, the Ministry of Health and New Zealand commissioners, as we know them, financed some support to practices on the change management and training on how to implement these portals, with short-term financial incentives available to practices to A, establish such a portal, and B, evolve their portal to offer certain functionality to patients. Now, by the end of 2019, almost 1 in 5 people in New Zealand had signed up for access, and it was offered by almost 2/3 of practices. But actually, most practices only offered a very limited range of services, such as access to lab test results, more than anything. And there is great variation in both the offer and really the patient sign up locally. And this is despite financial models and tools commissioned by the GP's own trade union, showing that you do save time and money as a practice if you digitize access and offer your patients access to services via the patient portal. But also patients themselves haven't, on the whole, been universally interested. Only those with reduced mobility and families with children being recognized as keen to proactively use those. So the less than perfect rollout and take-up showcases, firstly, that because of the additional co-pay patients pay for appointments in New Zealand, a supplementary amount of money they have to pay for every GP appointment, if you like, there's this unease of charging patients even more for use of the patient portal. And B, on the practice side, practices don't feel compelled to change their day-to-day operating model to shift to digital without additional and ongoing funding by the government. These 3 different examples highlighted how you not only need to have the right digital service, but then also need who will pay for it and who will want to pay for it to make a success of it. And I will finish by talking through the following examples where I'll be highlighting the role of organization and management of healthcare as a factor affecting one's ability to then deploy innovation. And I will start by what I call an unsuccess. And I know it's a made-up word. So in New Zealand, this example showcases the need for decision makers to think twice and differently when it comes to rolling out digital innovation that requires a series of parties to work together and make decisions together. So a New Zealand District Health Board, which is the equivalent, if you like, of the NHS's, English NHS's, clinical commissioning groups, CCGs, and NHS trusts, the providers, into one, or actually closer to the Scottish Health Boards. One such District Health Board purchased and deployed the telehealth app. They hoped the app-based telehealth solution would be of particular benefit to rural and high-need groups, achieve cost savings by reduced hospitalization. So far, so good. So the senior management there identified a single, relatively small telehealth company in California, mainly offering their app to small insurers as a white label product, purchased it without carrying out any competitive tender process, no risk analysis, no identification of internal and external stakeholders, and existing or new collaborations that would be needed to make a success of the purchased solution. Now, in the end, only 2% of the resident population signed up to the platform during its life, and only 1/10 of those made use of the app's feature to contact a doctor, which resulted in a very low total of 3,000 consultations made through the app. And that meant that actually each consultation effectively costed taxpayers about £4,000. In addition, only a fifth of the targeted clinicians went on the app and were available through it. Now, this is a public knowledge, and a lot of reports have been written about the failures there, but it showcases how decision-making for digital innovation made in a culture of isolation, which included not engaging with clinical leads and providers by forcing a new solution upon them, is not the way to go. Moving on, in Australia, like everywhere else, the decision makers for different aspects and tiers of care sit on different levels and tiers of government, from the federal to the state to the regional to the local. Nothing new there. With a new and the very first national digital health strategy that they developed a couple of years ago or so, the federal government had to decide how to then roll out and evaluate major projects that it wanted rolled out everywhere, such as the new national health record. Now, because many healthcare decisions sit at state level rather than the national approach developed meant that large-scale projects are at first piloted, tested, and finessed at state level, but in different states, before then shared with the other states when ready for deployment, but with the prior benefit of prior large-scale testing. This allows different states to test different solutions, and when they are ready, they can be spread everywhere, but they're nationally organized and led. I will finish this, and indeed the presentation, by talking about the coming together of delivery and insurance and decision-making for those and how that affects the digital journey. Now, mindful of what I said about the importance of integration, not only of provision, but of the purchasing, commissioning of services, or indeed the funding of services, it is worth to highlight that in the US, there are major changes that are continuing to take place that affect how digital innovation is introduced or embedded in day-to-day healthcare. And these are actually outside the control of the consumers, or indeed the frontline, if you like. So firstly, the last decade has seen more and more integrated systems, which I referred to earlier, which have already brought together all the providers across a care continuum, but now they're also starting to incorporate one way or another the payer aspect. So provider systems have been partnering with existing health insurers to create joint ventures, acquiring health insurers, evolving from an accountable care organization, ACOs, remember those, into a licensed health insurance company, the lot. And therefore, I will finish off as I started by looking at the future of integrated digital healthcare. There is a major transformation of healthcare delivery models happening. While one does need bricks and mortar hospitals and clinics, for everything else, you now have large employers, Amazon, Apple, Walmart, rolling out their own digital-first service for their staff for free or for a low fee, which includes asynchronous and synchronous modes of consultation, online chatting with your GP, video consultations, and so on, as well as face-to-face care through home or office visits by nurses. Now, this isn't anything new per se. The difference, however, is that A, these are in-house services, and more importantly, B, that these companies are really testing the ground to subsequently, potentially, develop a commercial offer for others to purchase from them. And it also showcases the agility and ability to create new models of delivering care of those large corporations. So I will finish in reverse order from how or what showcased today with these thoughts. At the last point, how existing healthcare systems, when it comes to deciding how to roll out digital, they need to stay as current as actually other industries if they are to meet the needs of their populations. On payments, digitizing patient-facing services will only work if all components and organizations involved, including patients who are relevant, have the right incentive and financial, if you like, positives and negatives, almost cash flow, if you like, balanced to go for a digital solution and service. And finally, vertical and horizontal integration across, within, between the separate providers we know and love in the NHS and other universal healthcare systems. Their integration is the way to ensure the best chance of digitizing care well, and actually for the right reasons and for the right benefits. So thank you very much for listening, and I'm happy to take any questions. Thank you very much.
Brilliant. Thank you so much, Dimitri. A really great and informative presentation there. I've learnt a lot. So we've had a few questions come in for you so far, but if anyone has any more questions, do feel free to ask via that Q&A button in the chat. But first one for you, Dimitri, is what are the things we should be doing at the NHS after looking into New Zealand's, Australia's and the USA's healthcare systems, as well as what to avoid?
Yes, thank you very much for the opportunity to present and indeed the question. I'd like to think that people that have now seen the, albeit brief presentation, will see that I have given such examples throughout my presentation. And of course, one can also read my overly long report on this, but it's fair to say that there is good stuff everywhere. And, you know, in some emerging economies, not the ones I visited, this may be because of them having no, if you like, baggage and starting from scratch when it comes to their healthcare systems, let alone the digitization thereof. So at healthcare system level, based on the robust, seamless healthcare systems and integration that I saw in the US and New Zealand, I would say the integration of services provision, the integration of decision-making on how to allocate money are the absolute must-dos in order to be able to also then digitize well our healthcare system. And of course, this is already in motion. Well, of course, the detail is being worked on following a consultation that the government did recently. In terms of what to avoid, so I think we should avoiding to ask ourselves the following. How much clinician, we should start quantifying and avoiding doing so. How much clinician and other staff time can we save by moving some activities for some patients online? And how do we ensure that this saving is then clearly allocated and used for the patients that need to be seen face-to-face or can only be seen in such ways? So making sure that people who can do things online and want to do things online are empowered to do so, and then we put the right focus and resources to those that can't or won't. The other thing that we should avoid, based on what I've learned, I think we should avoid creating new digital services without the end-to-end pathway consideration of the impact of those. So in healthcare systems with defined budgets and limited out-of-pocket expenditure like here, we can't blindly copy from everywhere, assuming that somebody will foot the bill at the end of the day. So that's the other thing we should be avoiding.
Absolutely, I love that. Avoiding things. Thank you so much, Dimitri. All right, second question we've had in is, what have we learned from our own strategy after the pandemic?
It's fair to say that, of course, the COVID-19 pandemic has so far caught everyone off guard. And it's also fair to say that actually we were fairly well prepared in terms of having robust emergency preparedness plans overall in government in the UK. And there's definitely some learnings we had from the WannaCry cyber attack of, was it 3-4 years ago now, in 2017, I think, which meant that we had to take a hard look at our digital infrastructure and make sure that things would work should such an attack happen again. The pandemic, of course, is different. But thinking more specifically to, say, online services towards patients, in England, we already were way ahead in that journey towards getting to where we got to today, and where we will get to in the future. So, for example, Denmark had such robust plans about an ability for patients to be able to text their GPs or message their GPs and use an app, but we were not that far behind. It was already since January 2019 when we had published a clear plan for the 5 years since from 2019, by which we would make sure that all patients had the right to engage with their GP practices and other services via online and digital ways. So that's good. However, thinking of what we've learned and what I think the other countries that I visited also learned, there was most definitely a liberalization and an opening, if you like, of the payments for digital services that took place in Australia and New Zealand and in the US. We had to worry less about that because we are a universal healthcare system where there's a defined kind of contractual framework and budgets for things. But that's what everyone learned, that if you want something to happen, you have to rightly make sure that you are able to pay for it in the short term. What's happening now in all of those countries that I mentioned is actually all the healthcare systems are thinking to themselves, okay, we dealt with the immediate issue of patients needing to receive healthcare and shifting as much of that as we can to online and paying paying for that. How can we now make sure that we get the balance right? These conversations are different in every healthcare system, as I said, depending on who pays for what.
Yeah, no, definitely. Great, thank you. All right, we've got one more question, unless anyone else has any burning questions they want to submit now. It's not too late. Obviously, you've touched upon this, both in the answers to the last two questions and the presentation, but once more, would you like to tell us, what does the future look like for a new NHS healthcare strategy?
Sure. Well, I mean, in some ways that is definitely beyond my pay grade, but it's fair to say that there have been so many, not only the last year, because, if you like, of the pandemic, but even the last few years, there's been so many good recommendations in so many good reports by think tanks and the likes, with really good insight of how a good NHS strategy would look like. But if I was to think of from my own perspective, there's definitely something about how do we embed remote monitoring in different parts of the NHS so that patients can be elsewhere, at home, in a care home, and being monitored remotely, so they only get the care that they need face-to-face when they need it, rather than being traveling all around the place unnecessarily, and actually be able to catch things earlier if people are monitored remotely, rather than just when they present at the A&E, for example. There's something about automating processes. There's a lot of stuff that happen, even if they happen digitally, not paper-based, but they still require a person on a computer to be clicking on lots and lots of boxes and ticking things and saving things, etc., and attaching things. There's a lot of that can be automated. So I think there should be something in a healthcare strategy about letting go of a lot of the manual processes that are needed. And I'll finish by saying perhaps video consultations. I think there is an opportunity to have more of that in outpatient hospital consultations, so that people don't need to go to the hospital just to have a 5-minute catch up with a consultant to be told that yes, things are looking fine.
Absolutely, such a good idea. Thank you so much. So we've got just under a minute left. Did you have any last words you would like to leave us with, Dimitri?
Well, it's been a great couple of days so far, and I hope people will continue listening to the presentations, as I will as well. And if anyone wants to get in touch, they can do so via my LinkedIn.
Perfect. Thank you so much. It's been really great having you on, Dimitri. We'll see you next time. Enjoy the rest of the conference.
Thank you.
Thank you. Amazing. All right. Well, then next up, we have a fantastic World Health Organization panel lined up for you. It features Sam Shah, who's the Chief Medical Strategy Officer at Newman, who provide medicine for men and knowledge for everyone. So we've also got Michelle Funk, who is Unit Head for the Policy, Law and Human Rights Unit at the Department of Mental Health and Substance Use for the WHO. We've also got Sarah O'Leary, who is CEO at NextLink, SafeLink and MissingLink, who provide accommodation and community support to women with mental health needs and survivors of domestic and sexual violence and abuse. And last but not least, it features Ahmed Hankir, the lead of public engagement and education at the World Health Organization, and he leads the Collaborating Centre for Mental Health, Disabilities and Human Rights at the Institute for Mental Health at University of Nottingham. They're going to be dissolving the stigma around mental health, a re-evaluation in light of COVID-19. This is going to be really interesting. Can't wait for this one, so I'm handing over to you all now.
Welcome to day 2 of the UK Health Week series. In a moment, I'm going to be joined by 3 experts to talk about dissolving the stigma around mental health and re-evaluation in light of COVID-19. I'm Sam Shah, the Chief Medical Strategy Officer for Newman, and I'm going to be chairing this session. And I'm pleased to be joined by Michelle Funk, Unit Head, Policy, Law and Human Rights Unit at the Department of Mental Health and Substance Use, the World Health Organization, and Sarah O'Leary, Chief Executive Officer at NextLink, SafeLink and MissingLink, and Dr. Ahmed Hankir, Public Engagement Lead at the World Health Organization Collaborating Centre for Mental Health, Disabilities and Human Rights at the Institute of Mental Health, Nottingham. Welcome to everyone. Very much looking forward to these presentations.
It's an honour to participate in this Health Week series, and I want to thank the conference organisers for having created a dedicated space in the agenda to discuss the important issue of mental health and well-being. For my remarks, I'd like to highlight the main issues around stigma and discrimination faced by people with mental health conditions, and then conclude by describing some recent work that the World Health Organization is undertaking to address stigma and discrimination and to introduce a person-centered, holistic and rights-based approach to addressing mental health. The first point I want to make is that the stigma of having a mental health condition and the associated discrimination that results from that stigma permeates all areas of people's lives. And this is true no matter which country or which region of the world people live in. An important cause of stigma is the false but widespread belief that people with mental health conditions are weak, unintelligent, lazy, dangerous, incapable of making their own decisions and unable to contribute to society. This stigma, which we're talking about, directly leads to discrimination, social exclusion and harmful treatment practices. Let me provide some concrete examples of this. First, people are unable to access healthcare for addressing their mental health and physical healthcare needs. Mental health services are often not available nor accessible. Also, many people with a diagnosis of a mental health condition have their physical health ignored, as everything becomes secondary to the mental health condition or is attributed to the person's mental health state. As a result, a lot of people are unnecessarily dying because of physical health conditions. Second, in the healthcare services context and also in the community, many people experience violence, abuse and neglect, including the use of seclusion and restraints, over-medication and other forms of coercion, all in the name of treatment. Thirdly, people are actively discriminated against in education, in employment, in housing and social services. And the last example I want to mention relates to mental health and guardianship laws in countries which severely restrict people from making decisions on all aspects of their lives, about their treatment, about how they're going to spend their money, about where they want to live, and so on. And instead, we see that decisions are made by others, whether that be a health professional, a family member, or a guardian. And this is extremely dehumanizing for people. So what is the impact of all of this? As you might be able to imagine, this has a profound negative impact on people's lives. The impact is one of overwhelming disempowerment, loss of identity and hope for one's life, isolation and rejection, loneliness, and also self-stigma, feeling worthless, believing the messages and signals from other people that you are a second-class citizen, unable and unworthy of the same rights as others, and unable to contribute and lead a meaningful life. Because of all of this, apart from the profound negative impact on people's quality of life, we also see higher mortality rates. Mortality due to suicide, due to unaddressed physical health problems, and also due to poverty. And a lot of this is because of the consequences of the stigma, discrimination and violations themselves, nothing to do with actually having a mental health condition. So what needs to be done, and importantly, what is the World Health Organization doing to combat stigma, discrimination, and to promote a holistic approach for people with mental health conditions? The first point is clearly that we need to tackle the stigma, discrimination, and human rights violations head on. We need to change people's mindsets and stigmatizing and discriminatory practices on the ground. We need to do this for all stakeholder groups, people with mental health conditions, so they know what their rights are and can claim them. We need to do this for health professionals, for policymakers, non-governmental organizations, organizations of people with disabilities, for families, and for entire communities, so people can change their attitudes and practices. And we need to do this on a massive scale if we're really going to be able to positively change societal beliefs, values, and mindsets. Reaching handfuls of people through traditional training and teaching methods will not be enough. Only by reaching and influencing thousands of people in and across countries will we be able to reach the tipping point required for sustainable change. All of this is not wishful thinking. The World Health Organization has developed training tools and an e-training platform to address stigma, discrimination, and to promote human rights through its Quality Rights program. These tools work by engaging people to understand these issues on a personal and emotional level through the use of exercises, debates, case studies, and scenarios. This initiative is being rolled out in 10 countries so far, and the WHO Quality Rights e-training platform has already started to reach thousands of people within and across these countries. Nearly 28,000 people are signed up for and are doing the Quality Rights training. In Ghana alone, which was the first to roll out this initiative, around 14,500 people have successfully completed this comprehensive e-training course. What is also really important to note is that the evaluation results of the training to date have demonstrated very real and dramatic changes in the attitudes, mindsets and practices of health practitioners, families and people with mental health conditions. Now, a second critical area for action that needs to be taken is to develop services and supports for people with mental health conditions that promote a holistic and recovery-oriented approach. And this means moving beyond a biomedical approach, which focuses solely on diagnosis, medication, and symptom reduction. We need to change how mental health services operate and what they deliver. And in this context, I want to mention some key characteristics required of holistic recovery-oriented services. So firstly, these types of services are about promoting hope and optimism for the future. This means believing that a person's situation or circumstances can change and problems can be overcome. Too often, people are given completely opposite messages that their situation cannot improve. It is so important to nurture people's dreams and aspirations and give people hope for their future. Secondly, they focus on connectedness and inclusion in the community. For example, helping people to reconnect with family and friends, develop new meaningful relationships, connect with peer support groups and other groups in the community. Thirdly, recovery-oriented services help people find meaning and purpose. And this involves supporting people to rebuild their life and gain meaning and purpose according to their own choices and preferences. Fourthly, they work with individuals to explore their identity. And this is a factor so integral to people's recovery. And that means supporting people to accept who they are, as well as to overcome self-stigma, which can often undermine a person's identity. And finally, these types of services help people regain control over their life. This means acknowledging that the person concerned knows what is best for them in their recovery journey, that they are the driver of that journey, and that their will and preferences must be respected. Having said this, I'm very pleased to announce that the World Health Organization has just finalised new guidance for countries to develop community mental health services that implement the holistic and recovery-oriented approach that I've just described. The aim of this new guidance is to show policymakers, service providers and other key actors that such services exist and make a real and positive difference in the lives of people with mental health conditions, and also to inspire them to take action to invest in and develop these services in their countries. In conclusion, addressing stigma, discrimination and violations requires fundamental changes to deeply entrenched attitudes, practices and services. Multiple actions need to be taken. None alone will be sufficient as a solution. Whole systems need to change. And these actions are necessary, not just because they are a good thing to do, but because they are essential to ensuring that people with mental health conditions are no longer treated like second-class citizens, but are instead finally able to enjoy the same rights and freedoms as everybody else. Thank you very much.
Hello, everyone. I'm absolutely delighted that I was invited to speak here today, so thank you. As a provider of mental health services for women for over 35 years, this is what women who access our service want everyone to know. They tell us that mental health can happen to anyone. It's not just something that happens to other people. There'll be people at this conference today who are struggling with their mental ill health. You can have a set of experiences that become emotionally overwhelming and you break, often after trying very hard for a really long time.
At Missing Link, we provide a range of community and accommodation support services to women with a mental health need, and also specialist support to victims of rape, sexual assault and domestic abuse. And Link House, our women's 24-hour crisis house, is included in those services. And like all the other services, it follows a social model of recovery. So it provides high quality and safe support to women that has an emphasis on the immediate crisis, but it also focuses on building resilience, increasing social networks, and maintaining good mental health when people return home. We all know the statistics that 1 in 4 people struggle with their mental health each year in England, and that 1 in 5 people have thoughts of ending their life. But I think these are conservative estimates. And the reason I think that is because women tell us daily that there are so many people who don't reach out for support when they're struggling with their mental health because they're scared. They're worried that they will be blamed, face judgment or prejudice if they tell anyone what's going on. And the women we work with want to change that. They want to end discrimination around mental health so that anybody can reach out for support when they need it. And most importantly, be treated with kindness and respect, the kindness and respect that they deserve to get. I'm going to talk about 2 women today, 2 survivors of mental health who've recently accessed our support services. They really wanted me to tell their story today because, like a lot of people we help, they really want to use their experiences to end discrimination and change the way people view people with mental ill health. So I'll start with Marion. Marion has struggled with mental health for most of her life. When she came into our house, she had a support session and she disclosed to her worker that she'd experienced childhood sexual abuse from her stepfather, and it had started when she was 7 years old. And by the time she was 12 years old, she was using self-harm to cope with this abuse. She was skipping school and she was missing most of her education. So when she was 16, she'd left school with no qualifications. And at this point, she met an older man who was abusive and controlling. Because this also created a lot of difficulties with her relationship with her mum, she ended up in mixed accommodation services for young people. And by the time she was in her early 20s, she'd met a new partner and she'd fallen pregnant. And so she moved in with him. Shortly after moving in with him, he also became very controlling and she relied on him completely. She relied on him financially because she had no training, she had no employment and she had no qualifications. So it was after the birth of her first child that she actually described to the worker symptoms of postnatal depression. But at the time when it was happening, she didn't tell anyone, partly because she was terrified that her child will be removed from her. Now, after the birth of her second child, this is when her partner left her for someone else, and that's when she had a breakdown. And she was then in and out of hospital over several months, and she relied on her mum for help with the children. When Marion came into her house, she said the reason she'd never sought support for her mental health before was because she was so scared that she'd been blamed or judged for her experiences. And actually, she did blame herself for what had happened to her. Until coming into Link House, she hadn't felt safe enough to be able to disclose the childhood sexual abuse. And actually, she'd never even been asked about her past experiences. She'd already been labelled as a difficult young person, and she'd internalised all these judgments. So she felt very strongly that she was lazy, needy, she was a bad daughter, she was a bad partner, and now a bad mother. She was terrified that her children would be removed from her care, and her self-esteem had been eroded from a really young age. Added to this, Marion had found that for her, the experience of being in and out of hospital had been a really chaotic, damaging and distressing one. And actually, it had triggered the memories of the abuse she experienced as a child. So throughout this, by the time she came to us, she just felt like she'd really lost her identity. Now, another woman, Priya, who is in her mid-40s, she started struggling with her mental ill health because she lost a close family member. And during this bereavement, she also lost her job. So this created financial pressure and also placed a strain on her relationships with her family. She started struggling with depression. She couldn't sleep at night, and she felt very isolated. So she did seek help. She actually went to her GP and said what was happening to her, and she was prescribed with antidepressants and also sleeping tablets. But then a month later, she took an overdose, and that's when she was referred to us. She told the worker when she first came into the house that the reason she'd taken the overdose is she just couldn't find any other way out of the really distressing feelings of constant despair and loneliness and pressure and stress that she felt. Now, both these women are well on their way to recovery, but what they do highlight and what they want you to know is that mental ill health can happen to anyone. It's not about a weakness or a personal failure. It's just about being a human being, and that life can be really challenging and difficult and often traumatic. What Marion and Priya say really helped them the most is that we treated them as individuals. They were the centre of their support plan, and we supported them holistically throughout their stay. So we didn't just focus on their mental health, but we looked at their whole self, all their experiences. We gave them the space to safely explore their past experiences and really validated the impact that these had had on their life and how they coped with the trauma from those experiences. We provided them with the practical and the emotional support when they were feeling really emotionally overwhelmed. So this meant that we supported them to engage with sexual abuse counselling for Mariam, for example, bereavement counselling for Priya, peer support, financial debt advice. But we also helped them with improving relationships with their children and with their family. They said that no one had told them how to get that help and support in the past, and that this had really empowered them to make informed choices so they can reintegrate back into the community. They also said how having a safe women-only environment was vital for them to be able to speak about their experiences openly with people they felt who understood them. It didn't just help with the immediate crisis, but most importantly, it made them realise that they were normal and that their responses to those traumatic experiences were also normal. And as a result, they felt much less isolated. They particularly valued the activities and the resources because they were tailored to their specific needs, beliefs and the interests that they had. And Marion commented that this made her feel like a person rather than a patient for the first time. After leaving the house, both Marion and Priya said that they felt much stronger. And this was partly because they now realised that the responses they had to all the experiences in their life were completely normal, actually. And also how they'd internalised other people's judgments and the damage that this had had on their self-esteem and their recovery and their ability to seek help in the first place. They both said that, and actually the women we work with often say this, that being treated with kindness at a critical time was vital for them. So when they came into the house, they were greeted with a smile and warm words. And this made a huge difference because it made them realise for the first time that they deserved to be treated in that way. And at a time when they felt that they didn't even believe in themselves, the staff around them believed in them and believed in their recovery. What they really want everyone to know and understand is that mental health is everybody's business, and there is never any place for blame or judgments. And your kindness could be critical for a person that you know who's currently struggling. So if you hear someone making stigmatizing or prejudiced comments around mental ill health, please challenge it. In fact, it's our collective duty to challenge it. There are people in this webinar today, as I've already mentioned, that may be struggling with their mental ill health, or you'll have people in your friendship groups or your families, and how you talk about it will make a huge difference or whether they can come forward and get the help that they deserve and need. That's why it's so important to eradicate any shame or stigma. Behind every woman who accesses our service, there is often a story, and I have to say it's normally a really tragic one. However, I see every day that with the right help and support, it is a story that they can recover from.
Hello, everyone. I'm Dr. Ahmed Hankir. I'm an academic clinical fellow in psychiatry at King's College London, and this is my presentation, The Wounded Healer, Harnessing the Power of the Performing Arts and Storytelling to Challenge Mental Health-Related Stigma. Now, I don't know about you, but my mental health took a real battering during the pandemic. And according to the president of the Royal College of Psychiatrists, Dr. Adrian James, the coronavirus crisis poses the greatest threat to mental health since the Second World War. Approximately 10 million people are thought to need new or additional mental health support as a direct result of the crisis. And there's been a 19% rise in people sectioned and admitted into acute psychiatric care. It's true, doctors are human too. The pandemic has placed a tremendous amount of stress and strain on the mental health of healthcare workers. And 709 HEWs from ICUs across England were recruited to participate in an anonymous web-based survey in June and July 2020. And 45% of participants met the threshold for at least one of the following: severe depression, PTSD, severe anxiety, or problem drinking. And 13% reported frequent thoughts of being better off dead or of hurting themselves in the past 2 weeks. So we are human beings too, and we are vulnerable to developing mental health conditions like everyone else. Now, according to a systematic review of the literature, persistent suicide is 28 to 40 per 100,000, which is more than double that of the general population. Now, there are three broad approaches to mental health. The first approach is being proactive. A healthy body is a healthy mind. Prevention is better than intervention. Being reactive, so if you're a medical student, for example, and you develop psychological problems, you will refer to a counselor on campus for psychological support. And the third approach is instigating systemic change, challenging the culture of shame and stigma that permeates not only medical schools, but the National Health Service. Now, stigma has been defined as a deeply discrediting attribute that reduces the bearer from a whole and usual person to a tainted and discounted one. The individual is thus disqualified from full social acceptance. A survey of over 2,100 female physicians who met the diagnostic criteria for a mental disorder revealed that 50% were reluctant to seek professional help because of fear of exposure to stigmatization. 50% of female physicians with a mental health condition were reluctant to seek professional help because of fear of exposure to stigma. So stigma and the culture of shame are formidable barriers to mental health care services, and consequently, many people with a mental health condition continue to suffer in silence despite the availability of effective treatment. That's why I'm indignant. That's why I'm outraged. This is Dr. Daksha Emshan. She was a brilliant psychiatrist with bipolar affective disorder, and she tragically killed herself and her 3-month-old daughter, Freya, during a psychotic episode. An independent inquiry into her death concluded that she was the victim of stigma in the National Health Service. Succinctly put, stigma is killing people. Stigma is killing people. Now is not the time to be quiet. So, stigma is an umbrella term, and it can be deconstructed into 3 main components: problems of knowledge, ignorance, problems of attitudes, prejudice, and problems of behavior, discrimination. This is important when you want to operationalize stigma, when you want to evaluate anti-stigma campaigns, because each component has a validated psychometric stigma scale. These are the 3 broad approaches to challenging stigma through protest, education, and contact. And a systematic review on challenging the public stigma of mental illness revealed that the most effective way of reducing mental health related stigma in adults was through social contact with someone who has recovered from a mental health condition. In other words, experts by experience have the power to reduce mental health related stigma and should be operating at the vanguard of any anti-stigma campaign. And it's not just social contact, it's also virtual contact as well, which is important because this is obviously the dawn of a new era with digital technology being leveraged to deliver talks and anti-stigma campaigns. Here we have an expert by experience, Prince Harry, and he was open and honest about his experiences with mental health difficulties triggered by the death of his mother, Princess Diana. And mental health charities report there was a surge in the number of people who contacted their information line. The mental health charity Mind, for example, report there was a 38% increase in the number of people who contacted their helpline. Experts by experience have the power to reduce mental health related stigma. So how do we react to stigma? We can develop self-stigma. We can internalize the public stigma. We can be indifferent. We're neither here nor there. And many of us can also develop what we call a righteous indignation. We become energized. We want to be agents of social change and contribute to that cultural revolution to reduce mental health related stigma and normalize mental health conditions. So many people with a mental illness often have to choose between concealment and disclosure. And Coming Out Proud is a program that offers support with making this difficult decision. And an RCT on COP revealed that it had immediate positive effects on disclosure and stigma stress related variables. And this is a manual, the Honest, Open and Proud manual for mental health professionals who have a mental health condition, which provides you with guidance. Now, Carl Jung used the term the wounded healer as an archetypal dynamic to describe a phenomenon that may take place in the relationship between analyst and analysand. Jung discovered the wounded healer archetype in relation to himself. For Jung, it is our own hurt that gives us our measure of our power to heal. It is our own hurt that gives us our measure of our power to heal. So when I was a medical student, I woke up one morning to discover that my hometown in Lebanon was bombed and that hundreds of people were killed overnight. And I developed a severe episode of psychological distress. However, debilitating though the symptoms of the mental health condition were, the stigma was far worse. And I was shunned, stigmatized, dehumanized by not only society, but people who I thought were my closest companions. And I was made to feel that I will never recover and that I will never amount to anything in life. This, of course, is a myth because I recovered and I received the Royal College of Psychiatrists Foundation Doctor of the Year Award. And the RC Psych Awards mark the highest level of achievement in psychiatry in the UK. That didn't just happen once, it happened twice. And I wanted to harness that story to challenge mental health related stigma. But any anti-stigma intervention has to be evidence-based and data-driven. And this is what the evidence states. These are the 6 key ingredients of anti-stigma programs for healthcare providers. And the Wounded Healer contains 4 of those 6 key ingredients. And it's been described as an innovative method of teaching that blends the power of the performing arts and storytelling with psychiatry. And the argument we make is, how can you educate an audience if you can't engage them? So we harness the power of the performing arts and storytelling to engage, entertain, and educate, to debunk the many myths about people who have mental health conditions that abound. And it's delivered by an expert by personal and professional experience, a mental health care professional with a mental health condition. And these are some of the flyers. So we delivered the Wounded Healer nationwide. And this is some of the feedback that we received from medical students, which is very positive. We delivered it to over 75,000 people in 18 countries and 5 continents worldwide. This is the footprint of the Wounded Healer. And we evaluated the Wounded Healer. We conducted a single-arm pre-post comparison study. We'll see that there were statistically significant improvements in stigma scores in all of the stigma domains. So this is for knowledge, this is for behavior, and this is for attitude. So this is the first intervention study to challenge mental health related stigma comprised of wounded healers. And it was associated with statistically significant improvements in respondent scores in all 3 stigma domains. And it contained all 6 key ingredients of effective anti-stigma programs for healthcare providers. So wounded healers can harness their trauma to help harmonize relations between healthcare providers and mental health care receivers. And it illustrates the colossal power of contact with an expert by personal and professional experience. Obviously, more robust research in this area is needed. Many people with mental health conditions report that medication was helpful for them. I don't dispute that. I'm a psychiatrist, but the power of the performing arts and storytelling is what contributed to my mental health recovery and resilience. Thank you, everyone.
Welcome back to the live part of the session, where we've now joined by Michelle, Sarah, and Ahmed for what is going to be a quite exciting Q&A. You have just heard what is a very moving discussion around dissolving stigma and mental health, and what an incredibly important topic. I'm sure everyone has got lots of questions out there, but I might take chair's prerogative and start us off. You've all given incredibly sort of passionate perspectives on why this is an important topic area and why it needs to really be addressed. Sarah, if I may start off with you, really, and just talk us through. You touched on there the issues around co-production and why it's important. What are your thoughts on how that's played an important role in really addressing this area and helping people get access to care and to support?
We wouldn't be providing the service that we're providing, and women wouldn't be able to live lives managing their mental health and actually thriving after acts of service if it wasn't for co-production being at the heart of everything that we do. It's so important, and I think there can be a real danger as well out there of people viewing it as a consultation or a tick box exercise. True co-production is throughout your whole system, so it's policies, procedures, governance, the development of services, specifications, commissioning requirements, and that filters down. For us, that has been the very heart of how we developed Link House. It was listening to what women with lived experience wanted, how they wanted to be treated, what would help them with their recovery when they're in a crisis, and then actually working with them to approach funders and say, this is what we're saying, this is what women are saying that they need. And that's how we end up being funded for Link House. And that's how the model was developed with those women. And we continue to do that as we, because guidance, best practice changes throughout time. And what Survivor's Voice, Ahmed, you touched on it, the pandemic and the impact that's had. So the need is ever changing. But I think the important thing is that if you've got that from a system structural level, it goes all the way down. So it means that on the ground, when you've got a support worker that's working with a woman, she is always the centre of that support plan. She decides, you talk about what those options are, you give that, and she makes those empowered choices for what is going to help her recover and go back into the community and not feel so isolated and be able to reach out for support whenever she needs it.
It really feels like it's a supportive sort of environment that's being created, a relationship where that perhaps that judgment doesn't exist, that discrimination isn't there, that means that dialogue can take place. Michelle, I know you touched on this, and I'd very much, like your perspective, because from everything you've said, it's very clear that mental health, the stigma of it, the judgment in itself is both discriminatory, but is contributing to erosion of human rights. I'd really just welcome your thoughts and perspectives.
Thank you very much, and I think you've made a very important point. So you often hear people talk about the fact that it's not the mental health, having a mental health condition, which is the worst part of it. It's the stigma and the discrimination that results from it. And this stigma and discrimination is really disempowering for people, but it also has an effect at the systemic level in that policymakers are less likely to invest in good services for people. There's still this attitude that we should remove people from society, put them in institutions. And if you actually look worldwide, 80% of the funding that goes to mental health is actually going to institutional care. And that is also a huge source of human rights violations in institutions. But I need to say, we also see human rights violations in the community mental health service as well. So We see a lot of seclusion and restraint being used. We see forced admission, forced treatment, and neglect. And if you actually look very closely at that, you see how stigma and discrimination is at the root of these issues.
I mean, it really does seem like there's a lot more to be done with policymakers over just changing their awareness and understanding of not just mental health, but the entire concept of stigma, but also the way in which they're using restraints. Do you think there's a movement? Do you think organizations such as the WHO or any other national, international organizations are having that leverage on governments?
There is a huge movement at the moment. It's really building up, and you see a lot more civil society groups advocating for change to address stigma, to address discrimination, to address the human rights violations that are happening in the mental health field. So this is happening in civil society. There's a lot more talk about it at the government level and in policy making, and also in the sort of global and national professional associations as well. So I'm confident we're going to be seeing a change in the next months. And actually tomorrow we're launching a huge piece of work and new WHO guidance on good practice, community mental health services that are person-centered and respecting human rights. And already the interest has been astounding, with more than 6,000 people who've signed up for that launch event.
Thank you, Michelle. I'm going to come over to you because, you know, you've both had an incredible and moving personal journey, but you've also had a profound impact and influence on many others, both in the workplace and globally from the work that you're doing. And I was really taken by something that Michelle said, but also that you touched on, and that's sort of the human rights dimension of it, but particularly in organizations like the NHS. And as a fellow clinician, and with my teams experiencing probably what you and your team have experienced over the last year, it's very difficult. We come through this pandemic period and clinicians are themselves feeling burnt out, but often unsupported. I would really like to, take your perspective on, do you think there's a lot more that organizations like the NHS and its various institutions should be doing for its healthcare workforce around making it a safer environment from a mental health perspective?
Yeah, definitely. Absolutely. And I mentioned the three broad approaches to mental health: proactive, reactive, and systemic change. And I mean, it doesn't matter how many Zumba classes you attend unless we address some of these kind of systemic issues. People keep talking about resilience, and obviously that's important. But if there's a workforce shortage, then healthcare workers will continue to experience emotional exhaustion, burnout, mental health conditions. These are some of the kind of structural and systemic issues that need to be addressed. And I spoke about how mental health related stigma is rampant in the National Health Service, and we really need to empower and dignify healthcare workers with a mental health condition, also known as wounded healers or experts by personal and professional experience. And we need to amplify their voices because the evidence is clear. We have the power to reduce mental health related stigma. And so we need to normalize mental health conditions in the workforce and contribute to this cultural revolution to break down the barriers to mental health care and encourage care taking.
And are you finding globally that despite some of the challenges in places like the UK, are you finding other groupings, associations around the world dealing with healthcare professionals, clinicians, others? Do you think they're taking this on board? Is the movement happening in other parts of the world?
I think we're making some progress. We have some traction. This is the digital age. And so we can harness the power of technology, social media. But I think there's still plenty more work to be done, especially in low and middle income countries. And I mean, just look, hardly any research has been conducted on intervention studies challenging mental health related stigma in low and middle income countries. So yes, some progress has been made. I mean, the take home message for me is that mental health related stigma is deadly, it's lethal, it's killing people. And we need to do something about it collectively. because silence is not an option.
I think that's a really powerful point for us to end on. You've all been amazing. Michelle, Sarah, Ahmed, you're fantastic. You're doing some great work. Thank you for joining us today. Thank you for your time for the Q&A, and thanks to the audience. Now I'm going to hand back over to Stephanie for continuing the show. Thank you.
Thank you so much, everyone. That was incredible. Great discussion had by all, so thank you. Our final presentation this morning comes from Thomas Sabinoa, who heads all initiatives related to the application of virtual reality in the healthcare segment at Quora. So as you might imagine, Thomas will be discussing working with VR in healthcare. Such an interesting subject. Can't wait to find out a bit more. So Thomas, the floor is yours.
Hello, my name is Thomas Nord from the Copenhagen-based company Quora Virtual Reality, and I am working with our healthcare-related projects on a daily basis.
My name is Merete Nordentoft. I'm a professor in psychiatry at Institute of Clinical Medicine, Copenhagen University, and chief physician at Mental Health Center Copenhagen. And I'm the PI for the Challenge project, which we got funded from the Innovation Fund. We will start our
Måske har du prøvet at spille spil med sådan nogle, jeg har på lige nu, virtual reality-briller eller bare VR-briller. Men de kan faktisk bruges til meget andet end bare underholdning. Hvis man for eksempel er bange for at flyve, hvis man kæmper med krigstraumer, eller hvis man som Per Oxenvad her har en sygdom, som gør, at man hører stemmer, ja, så kan brillerne måske hjælpe. Forskere og psykologer rundt om i landet undersøger lige nu, hvordan man kan bruge VR til at træne mennesker med de her lidelser i at blive konfronteret med og håndtere netop det, de er så bange for.
Øjenfarve, kan du sige det?
Ja, greenish, skin color light.
Men tager vi et smugkig ind i fremtiden, så kan VR måske også hjælpe mennesker, som er plaget af noget, der kun eksisterer inde i deres eget hoved.
And the nose is a bit smaller too.
For eksempel det at høre stemmer.
VR distance is it's a bit closer.
Det gør 33-årige Pia Oxenvad her.
I'd say something like this.
Hun har paranoid skizofreni.
Det er 3 mænd, der hele tiden taler til mig bag mit højre øre. Jeg føler, som de står klods op af mig.
Det du ser på skærmen er en såkaldt avatar. Et ansigt, der ikke bare skal ligne, men om lidt også lyde, som en af de stemmer, Pia Oxenvad hører.
Nu hvor den lige pludselig begynder at se lidt virkelig ud, så kan det godt være, at den bliver lidt mere skræmmende at have tæt på.
Hun er med til at teste prototypen for et nyt program, som forskere fra Psykiatrisk Center København er i gang med at udvikle sammen med VR-firmaet Quora.
Det vil ikke være så skræmmende i sådan en grad, at du vil sige det, at det kunne slet ikke være i, eller jeg må lukke det ned. Det. Okay, det er godt at høre. Igennem den her avatar, så vil vi have mulighed for at gå ind og tale som patientens stemme. Og på den måde så får vi faktisk en mulighed for at lave en dialog, eller patienten får mulighed for at lave en dialog med sine egne stemmer. Og det er nyt. Skal vi prøve at kigge lidt på stemmen også?
Ja.
Er du mod på det, Pia?
Ja.
Og prøv så at lytte.
Op gennem forrige århundrede tiltog i Danmark den særlige form for kærlighed, der kaldes medfølelse.
Udviklerne forsøger at tune sig ind på den stemme, Pia Oxenvad hører for sit indre øre.
I think the pitches have to be turned a little bit.
De kan skrue på for eksempel alder og køn.
It should have a little bit of vibrato.
Og på hvor meget stemmen vibrerer.
Maybe I think there is actually pretty close.
Og så er det blevet tid til et kort møde med stemmen i VR-universet.
Sådan.
På lang afstand, fordi det er første gang.
Så nu sidder den helt dernede. Kan du se det?
Ja.
Hvordan føles det?
Det føles okay.
Kunne du have mod på at prøve at sige noget helt neutralt med avatarstemmen, så du lige kunne høre den?
Ideen er,
det kan vi godt prøve,
at psykologen undervejs i terapien skal kunne slå avatarstemmen til og fra.
Nu taler jeg med din
avatarstemme.
Og på skift agerer den ubehagelige stemme.
Kan du høre mig?
Ja.
og med sin egen stemme guide klienten til, hvordan vedkommende kan takle den.
Nu skifter jeg ud igen.
Nu er det mig igen, Pia. Når man går ind i den her dialog med sin egen stemmer, så får man lige pludselig muligheden for at svare igen til sine stemmer, for eksempel. Sige, jeg gider ikke at høre på dig, eller nu skal du ikke blande dig, eller du har ikke ret i det, du siger.
Okay, jeg prøver lige at snakke lidt mere, ikke? Jeg snakker lidt højere. Det er noget, jeg kan se, det er i hvert fald, at jeg bevæger, altså avataren bevæger læber. Kan du se det også?
Det kan jeg også se.
Håbet er, at det kan dæmpe angsten for stemmerne.
Jeg har prøvet noget kognitiv terapi, jeg er på medicin. Det har jo ikke hjulpet endnu. Så jeg håber, at det her det kunne være med til at skubbe det i den rigtige retning.
Flot klaret, min ven. Flot klaret.
Tak.
Projektets forskningsleder, Merete Nordentoft, har også store forhåbninger. Men før virtual reality for alvor kan gå hen og blive fast inventar i psykologernes værktøjskasser, så skal effekten dokumenteres.
Vi kan sagtens se perspektiverne, men altså, teoretisk set kunne man jo godt forestille sig, at det, der skete, det var, at vi kom med en hel masse isenkram og forstyrrede den udmærkede terapeutiske alliance, der var, og det terapeutiske arbejde, som foregik i forvejen. Vi skal være sikre på, at det, vi foretager os, at det er mere fornuftigt, end det, der foregår i forvejen.
That was Merete doing a deeper dive into the challenge project. And as mentioned before, my name is Thomas. I work with a lot of the healthcare related projects at Cora. And Challenge is one of our larger healthcare projects. We are a 5-year-old Copenhagen-based company located in the meatpacking district in Copenhagen. And this is an image from or photo from our showroom, which is open 7 days a week. It's a little bit lower frequency here during the Corona period, but things are picking up slowly. But besides having this showroom, we are doing productions in VR and AR within all different kinds of fields like architecture, education, marketing, tourism. But we have always, since the beginning, had a strong focus on healthcare because there is a huge potential in the healthcare field for virtual reality. And this is just like a bragging slide. We have done a lot of productions with a lot of interesting companies, but that's not that important for this presentation. What we see virtual reality being is kind of an evolution of the internet. And I'll explain a little bit later why that is important. In the end of my presentation, I will show some really practical examples of how VR is being used in other areas of healthcare. But the internet has been moving from being an information-based medium to an experience-based medium. It has been text and then more and more images and videos that you have been seeing in your Facebook feed, for example. And if you look back, then this is, for example, Apple's website 20 years ago. This is how Apple's website looked today. This is Netflix that we all know from when they rented out DVDs. But today it's just straight on to the experience that instead of giving a lot of information over the internet, you give experiences to people. So what we see is that the next evolutionary step of the internet is virtual reality or augmented reality. And this is just a last non-healthcare related example, but if you are, for example, in high school and writing a paper about the Great Wall of China, right now you would be looking up information on the internet, on Wikipedia, about the Great Wall of China. But in the future, you would more be experiencing the wall, standing on the Chinese wall, the Great Wall of China, as a guard and defending it against Genghis Khan or building it. So interacting with what you're about to learn something about. Also, this has always looked like this. If you're buying a bottle of wine on the internet, You can read about it. It's not really that exciting, but in the future you would be able to stand in the vineyard and have the farmer talk about how the wine is produced. So moving more and more towards experience. And that brings me to something more healthcare related, because these qualities or affordances of virtual reality can be harvested and used in healthcare related contexts. So this is an example from a project that we did in a Danish hospital being built. It's when you build a hospital, you have to plan out the scale and the equipment and how it will be used when the hospital, or in this case the operating theater, is actually in operation. So this is a simulation of scale, like you can place equipment, you can see if there's room to move around in the operating theater. And that was used in workshops, as you see here, with clinicians, with nurses, for example, so they could jump into their future workplace, move around, comment to the architects on if they believed that it's the right proportions that the operating theater is built. This is another example of how you can create value with virtual reality. This guy in the bed, Björn, he suffered from ALS, and his wife Lene called us and said that when he was not ill, he went to this place outside of his hometown, like a hill with a beautiful scenic nature, and she went to this place, recorded a 20-minute video with this small 360 degree camera, and then went back and put it on his head and gave him an experience that he no longer could get because of his illness. Another area where there's a lot of potential for this is within pain distraction. We have built a rather simple game. It's not rocket science. It's a game that is designed for this procedure. It is a child having an IV inserted, and that can be rather traumatic before a child is going through surgery. Then the needle itself can actually be more traumatizing than the surgery. So we have designed this game that the child plays during the needle procedure. And the child now, this video is in Danish, so no reason for sound. But what is going on is that the nurse prepares the hand of the child, and the child is completely immersed in this VR game. And he then can't see the needle when it's going in. Very important to mention that we're not trying to cheat the child here. The child is knowing when the needle is going in. So it's just a distraction of this expectation of pain. And this is something that is just not a trial. It's out in 12 Danish hospitals, a couple of Norwegian hospitals, and a German hospital. So that is being used on a daily basis. Then the last project that I want to mention is actually another project with Merete and her team in the capital region of Denmark. It is still, to my knowledge, the largest clinical trial using 360 video for exposure therapy for patients with social anxiety. And it is a number of scenes that is created, anything from a supermarket to presenting in front of a group of people, to going to a social gathering, a party, very Danish party in this case, in a kitchen, but where you can do exposure in group sessions in a controlled manner, so that instead of telling patients or taking patients out to exposure in real life, and telling them to go to a supermarket, bringing the clinicians to the supermarket, or giving patients homework. This is a controlled way of exposing to more and more challenging situations, and thereby training and being in these social situations. And of course, we hope that this is a way of scaling or hiring the quality of treatment for patients with social anxiety. But I hope that that gave you a little bit of an insight into some other application areas. We always, if projects need deep clinical knowledge, that is not something that we as a private company have. So we, as to what degree we can, work together with researchers, and then we are mostly the experts in producing the material for these research projects, so programming it, making graphics and sound for the projects. So that is why it's so great to work together with skilled researchers. But yeah, in a couple of seconds, you can ask us questions about these projects, and yeah, thank you.
Well, thank you. It's a pleasure to present the challenge project for you. It is about fighting auditory hallucination by simulation training in a virtual environment. And it's a project which involves several Danish regions. We have 3 Danish regions involved where the trial is going on, and then we have a close collaboration with Cora Virtual Reality. And here you can see the names of some of the people involved. The background is that we know that people with auditory hallucinations suffer from having these experiences. On this slide, you see a 10-year follow-up of a large group of patients with first episode psychosis. Not all of them heard voices from the beginning. Some of them heard voices from the beginning, but they disappeared during the years. But what you can see on this slide is that there is a group of patients, 13% of the patients who had marked hallucinations all the time when they were interviewed after 1 year, 2 year, 5 year, and 10 year. And there was another group who also had auditory hallucinations, a group of 10% who also had auditory hallucinations, but not as bad as the upper 13%. So it is indeed a problem that some patients experience during the course of illness when they suffer from schizophrenia and related disorders. And on this slide, I've taken some examples of what it is they actually hear. And what you can see is that it is actually very unpleasant. It is, for instance, commands that you should take an overdose or jump off the bridge, or that it could also be that the voices were trying to interfere with the treatment and, for instance, encouraging the patients not to take their medication, things like that. And it could be threats that they will be killed or their relatives will be killed. So as you can see, it is really something you'd like to get rid of. These are just some examples, but I think we hear the same all the time, that the voices are they are very aggressive, and they really try to put you down. So our idea was to try to help people with auditory hallucinations, and we know that cognitive therapy is helpful. It has helped patients with trying to identify tools to alleviate the stress associated with the psychotic experiences. But this is completely different. It's not only about alleviating the stress, but it is something entirely new and flexible, because we join the patients direct into their universe and help them in their fight against the hostile voices. So the idea is to give the patient more power and control, and the virtual reality can be a modern and flexible framework. Yeah, We have developed a manual. The study was based on the study carried out in UK, the Avatar trial, and it was published by Tom Craig and colleagues in 2018. We were very inspired by that, and we collaborated with the group in UK, but we have developed our own manual. It is in Danish, but of course it can be translated. And in that we have included also elements from compassion-focused therapy. We know from the trial in UK that it was effective. There were 150 patients randomized into two groups. One group who had the Avatar treatment and the other group who had supportive talks with their therapist. And these dialogues with the voices that they hear, it helped the patients to reduce the distress and frequency of auditory hallucinations. So you can see the red lines here are how things developed with regard to distress and with regard to frequency of voices. And both these elements went down, and also the total element, when they were added up, it was also better. So that was what gave hope, not only to our group, but to a lot of groups all over the world. And here we have another picture of what they found in the UK Avatar trial, where they found that there was an effect again on frequency and distress associated with auditory hallucinations, but also on other issues, beliefs about voices and voices acceptance scale. So all in all, it was a relief for the patients to experience that they experienced after having been treated with the Avatar treatment. So that was very inspiring for us. So we more or less replicated what they were doing, but we added another session and 2 booster sessions. They are each last 50 minutes. At 15 of those minutes are with confrontation with the Avatar. And then when the therapist voice is transformed into one of the voices that the patient hear into their head, they are then exposed to that voice in those 15 minutes. And the dialogue is recorded, and the patient can have it with them home. So for the first time in their life, it will be possible for them to share their experiences with relatives and friends, that they can hear what kind of voices is it actually that the patient experiences when they hear voices. So we have the confrontative dialogue, where the patients gradually will have increased power and control over the voice. That's what we are aiming for. And the therapist can control the voice, so they can also make the voice gradually more compassionate and less evil. So that the voice, I think the examples are mostly that the voice gets surprised, that suddenly the patient seems to be stronger, and the voice can express that. Then there'll be a focus on self-esteem and identity and hope for recovery. Here you can see how we were working with it when we were trying the equipment, and we were previously people wouldn't know how it was to hear voices. Now they can hear it with their own ears. And what we found was that there was a reduction of duration and content of voices. They became less aggressive and more neutral, and it even happened after a few sessions. Of course, we'll have to try this out in a larger study, and that's what we're doing now. Yeah. So what we are hoping for is that the patient will get an increased sense of being in control, and that it won't be like that the voice is always stronger. They hope to be able to create a more symmetric relation and thereby increase self-esteem, and also learn how to handle anxiety related to the voices and better regulation of emotions. So what we are doing first is that we are we are making an avatar that looks like what the patient imagine in their head when they hear the voices. And we do that by using this drawing program where you can change the features of the avatar. So it can be a man or a woman. We can change everything. We can change hair color. We can change how old you look, and we can change whether you wear glasses or whether you have a beard. Yeah, here are some examples. But we can also change the voice, and we can change it whether it sounds like a man or a woman, whether it's an old person or a young person, and also the pitch and the size, the presence and the trembling. So the purpose of this is that the voice should sound as exactly as possible as the voice that the patient hear in their head. So that's what we are aiming for with this voice transforming program. So the therapist can sound both as him or herself, and the therapist can also be this evil voice and alternate between those two options. So we have started to recruit patients in November, and we are recruiting in all the 3 sites in Denmark. And we plan to do this recruitment for 2 years. And what we hope is that it will help on, again, the frequency and the distress associated with the voices, but also on other features such as hopelessness and self-esteem. The reason why we are doing it in virtual reality format is that the trial in UK was done in more or less a Skype format, where you sit in front of a screen and the patient and the therapist will have to be in 2 different rooms. But what virtual reality makes possible is that it can be more immersive, a real life version, and hopefully thereby more therapeutic value. It also gives us a lot of possibilities for changing the avatar, and it is a portable format, which is not dependent on 2 rooms. We can bring this equipment to the patient's home, and we can actually conduct the treatment almost anywhere. So it's suitable for home visits, and then we also hope that we have a future-proof software. So that's how it looks, that the patient and the relatives are linked together via the laptop, and the patient see the avatar in the goggles, and the therapist speaks through a microphone and can sound either as him or herself or as the evil voice. And the patient is wearing noise-cancelling headphones, so they cannot hear the therapist's real voice. So that's our plan, to recruit 266 patients and randomize them into 2 groups. One group who will get treatment as usual. We have asked the people in the ordinary treatment whether they can provide 7 consultations with supportive counseling during the trial, and they've promised to do that. And then the experimental condition is that you get the avatar treatment, you get the treatment with the voices in virtual reality format in those 7 sessions and the 2 booster sessions. Then they are followed up after treatment and again after a follow-up. Yeah, so we have started recruitment in the capital region, in region of southern Denmark and region of northern Denmark. And our experience so far is that the treatment is strong. And in some cases, we have to move very carefully forward. And for instance, not make it a 3D experience in the beginning, start with a flat screen, and then maybe after in the next session or the next session again, make it full 3D and more immersive. But our experience is that the treatment is very strong. And then we have this unexpected gain. It wasn't really planned, but the patients can take a photo of the avatar and show it to their mother or their boyfriend or girlfriend and share it with their relatives. And also the fact that they can play the dialogue so that the relatives can hear it. And that means that I think there's an element of destigmatization in it, and that the patient feel that others can better understand what they are really experiencing. Yeah, so that's about the end of my talk. We believe that by doing this, we can help patients to fight auditory hallucination, and we can do it by this simulation training in a virtual environment. So thank you for listening.
Oh, brilliant. Such a great presentation. Thank you so much. And now we are joined live by Thomas. Thank you so much for joining us.
Thank you for having me.
Thank you. So if anyone does have any questions for Thomas, please do submit them via the Q&A button. We have got some coming already for you, so we'll start with this one. How can VR lessen the symptoms of schizophrenia?
Yeah, now I'm not a clinical expert. I have a technical background, and Merete is the clinical expert here. But it is a type of exposure treatment, so you can actually role play and expose yourself to the malevolent voices that you have in your head. And normally it's very hard to externalize these voices. So by making them an external thing, by role-playing with the therapist, you can stand up to the voices, and if the voices are saying like negative things about you, you can step up and say, no, that's not true, I am actually worth something, and so forth. So it is a type of exposure treatment, and also like empowering yourself towards these malevolent voices. Yeah.
Absolutely, it's really incredible. Thank you. So the next question we've got for you is, what are the challenges for introducing VR in healthcare? I'm sure there are many.
There are many, and as I told in my presentation, we're doing solutions and projects within many different application areas. And of course, it's a rather new technology. So that's the first step. Introducing new technology in the healthcare sector can be challenging because hospitals and the healthcare sector has a certain way of doing things, and introducing something new takes effort, and it takes like open-minded thinking from the clinicians and departments. And I'm not saying that the whole healthcare sector is conservative, but the system as such are, of course, very, very dependent on doing safe treatment and evidence-based treatment that they know work. So that of course makes a lot of sense. But introducing something as virtual reality in healthcare takes evidence, takes collaboration with researchers and clinical staff that really knows the field in a very deep way. So you have to work together a lot and put aside resources for implementation and randomized trials and so forth. So it takes extra effort comparing to just developing software for almost any other industry.
Yeah, definitely. And how have you found trying to, introduce it into healthcare systems so far?
I think we have quite a lot of success. Like the challenge project that was introduced here, that's absolutely a medical device. So that's within the regulated area. But we have introduced pain management for children in, I think it's 12 Danish hospitals now, and a couple of Norwegian and a German hospital. And that is a distraction. So it is, it's not a regulated area. It is compared to telling a story or blowing soap bubbles or holding up a teddy bear and distracting a child that is, for example, having a needle procedure done or a blood sample taken. And it is fantastic to see nurses and doctors like welcome these new initiatives into the sector, because it's like a new tool in their toolbox that really helps and support their good work that they're already doing. But when they have an extra tool in their toolbox, it really makes them feel good about their profession, and especially working with children, that they can perform the procedures that they're doing in a like in a comfortable manner. Like our product is called Comfort XR, and it is about comforting young children when they're having a rough time at hospitals.
Absolutely. I can imagine there are many adults who would like that as well. As I was watching, I was thinking of all the procedures, you know, I can't remember the name of the one where you kind of go in the tunnel. Is it an MRI? And a lot of people can get quite claustrophobic. And I was thinking the VR on in that would be amazing.
Yes. And that is absolutely something that we have done a few years ago, doing simulation training for MRI scans. And also young children, again, more than 50% of children under the age of 9 are actually in full anesthetics during MRI scans because they are not able to lie completely still. So training that procedure at home with your parents in a safe environment is really, really beneficial, or at least that's what we think it's being tested as we speak.
Yeah, absolutely. So incredible. Thank you. So we've got one more question for you. If anyone does have any more questions, it's not too late to submit them now, but this last one for now is, what are the long-term effects for a patient being treated with VR, and do we have the evidence to show that it's safe?
That is a really big question, and within schizophrenia, it's a really serious illness, and it can have very grave effects if there are side effects, or if the treatment is not going as planned. So that is why we're doing it with clinical researchers and experts, and also why we're doing this randomized clinical trial where we can pick up these elements and really take it very, very serious. But it also depends on the application area, because distracting a child during a needle procedure with a more or less a computer game that they play, that it's very unlikely that it can have negative side effects, right? But treating something as a psychological illness can be something completely different. So it really depends on the application area. Like, as such, VR is safe to use. Like something like cyber sickness or getting nausea during VR is something that is almost solved by learning how to apply it the correct way, not having movement and things like that during the VR. But that it is super, super dependent on what you are trying to treat, because it is a very, very strong medium, and of course, using it incorrectly can cause harm. Yeah,
absolutely. Thank you. We have had another question come in, actually, which I think is a really good one to end on. So the question is, following on from VR providing experiential treatments, how else might we see VR and AR manifest itself within the healthcare industry, do you think, Thomas?
I think it will actually be almost everywhere. Like when building new hospitals, it's being used in the construction process, so you can step into future surgery rooms. It will be used as entertainment during hospital stays. So if you are at a hospital, now the best thing that you can have is maybe your smartphone to entertain yourself, or a TV screen. But in the future, you would be able to teleport yourself to exotic destinations, or like trying to alleviate the distress of being in a clinical cold environment. If you want to take a break from being at hospital, you can put on the VR goggles and transport yourself to whatever exotic, warm, nice destination that you wish. And then, of course, a very important one is within education. So training clinical staff, simulation training. Right now, it's mostly being used for surgery, but it could very much also be for simulating interpersonal training. So how to communicate towards patients, towards your colleagues. So I would say simulation training is a really big one.
Yeah, absolutely. That's the one that popped into my head first, is probably the most crucial in terms of safety, because it must be much less pressure to perform a pretend VR surgery than your first surgery on a real person. It's incredible, absolutely amazing. Well, I can't wait to see where this all leads to. Do you have any last words for us before we finish, Thomas?
Like if there are listeners from the UK, we would love to do more collaboration with the UK healthcare system. So of course, reach out. We are absolutely open to international collaborations. So yeah.
Absolutely. I'm sure you can be easily found on LinkedIn. So do reach out to Thomas if you're interested. Thank you so much, Thomas. Really great to have you here, and we will see you next time.
Thank you for having me.
Thank you. Brilliant morning then. Thank you so much to all of our speakers so far and for all of your input at home. It's been brilliant. Now time for a short break though, and as I said yesterday, we do encourage you to take this time to stand up and move away from your screens and give your eyes and brain a really good rest. If it's sunny where you are, maybe go and enjoy that. But we will see you back here in 45 minutes for the PM session. See you then. Hi everyone, welcome back. I hope you're suitably refreshed and had a lovely break. So this afternoon we've got another brilliant session lined up for you. We're shortly going to hear from Jenny Scott, who is the General Manager at the UK International Healthcare Management Association, which is also known as UKMI. Jenny has extensive experience of UK healthcare services, acquired over 32 years of senior management leadership within the NHS. She's going to be talking about the UK expertise in the global healthcare market. So Jenny, I'm handing over to you.
Well, good afternoon, everyone. I'm Jenny Scott. I'm General Manager in UKIMA, which is the United Kingdom International Healthcare Managers Association, and I'm absolutely delighted to be here with you this afternoon to tell you a bit about my organisation and our ambition for international healthcare. So, UKIMA is a unique organisation. It was established 8 years ago by Healthcare UK, which is a part of the British government arm that promotes UK expertise internationally. And our membership includes both large-scale commercial bodies such as Mott MacDonald and GE Healthcare, through to smaller scale subject matter experts with particular specialist expertise. We also have a number of NHS organisations with more specialist healthcare offers, and increasingly a number of academic bodies, universities, who are joining UKIMA. What makes us unique is that under one umbrella, we can tailor solutions for international clients. And that might be a large-scale capital build with all of the equipment and the staffing within that, or a very specific defined solution, reviewing services or implementing digital technology. So we can tailor and be responsive and flexible according to what our clients require. So the capabilities of UKIMA, because we have over 50 members, all different organisations from both commercial and public sector, we have a wide range of capabilities that we can offer international clients. Those range from expert clinical advice. We have a number of prestigious NHS organisations as our members with a wide range of clinical skills and experience. We have financial expertise. We're a partner with UK Export Finance, and we also have access to different financial solutions for international schemes, and also advice regarding financial modelling should a client need us to support them with that. We build healthcare facilities, be they large or small scale. We're very much involved in the emerging Healthy Cities initiatives, and so we can bring that expertise. So we have architects, construction companies, engineers. So it's the full turnkey solution for any kind of healthcare facility build. Increasingly, we're being approached around education and training, and this is where the digital element really comes into its own, in that we can offer both academic and vocational training, both specialist skills training, and a lot that we can do through digital learning platforms, which allow the client to access a learning management system digitally, and then we can work with them. So this is a big growth area for us, which is why I think we're seeing increasing academic bodies joining UKIMA. Digital and data technology, clearly that's of paramount interest in the series of these talks. So we have companies with a whole range of digital expertise and data modelling. So it might be a client wants us to work with them around a health strategy to do some data modelling around need. So we can offer that whole package solution. We also have a number of companies with specialist equipping, so that might be the more specialist equipment required within a healthcare setting. So these are all of the capabilities that we can offer international clients. As I mentioned, we have a number of prestigious NHS organisations, and I have a background in specialised healthcare within the NHS, and we find a lot of our international clients are interested in the more specialised end of care. So that might be things like neurosurgery, critical care, dialysis care, and we have a number of NHS organisations that can offer that within the context of might be within the context of a build or as a specific offer. So we wanted our members to be fully engaged. We're a membership trade organisation, and our members are crucially important, clearly, to our success. So we wanted to find a way of engaging with all of our members and involving them in our offers to international clients. So we established a number of special interest groups reflecting the capabilities and skills of our members. So as you can see here, we have an education training one, which, as I mentioned, includes both academic bodies and also specialist NHS skills training. We have health consultancy, so that might be looking at different service issues. It might be looking at developing organisational development, a whole range of consultancy aspects. We have the healthcare infrastructure, which, as I mentioned, is your architects, engineers and construction companies. We have healthcare operations and management. So not only do we build facilities, we can also operate them, commission and operate them, ensuring the equipment in there and also providing assurance to the client on value for money in the operating of that healthcare facility. We have a digital and data special interest group, and I know that Simon Swift, who was one of our co-leaders, spoke at one of the sessions yesterday. We also have a number of task forces. We have a particular task force now in the Middle East and North Africa region, and we're also looking at establishing other task forces. We have special projects, which are time-limited projects, and we developed a COVID offer last year in response to the pandemic. So each of these groups, our members can join any or all of these groups. They have 2 leaders, and each one of these groups has produced a brochure which describes their offer, outlines the capabilities of their members, and also showcases some of the case studies of work that our members have undertaken. So these brochures, which can be made available, they're on our website, really show our clients the offer and the specialist expertise that we can bring to their particular project. So the first one is the digital and data special interest group. So as you can see on that little computer screen, we do have a number of companies involved in this, and they're both public sector and private sector. And they bring different elements to this offer. So in terms of the digital offer, what we would do is we would work with international clients, we'd understand their need, their ambition for change, and then we'd tailor a solution around their particular requirements. So we offer both to our members the solutions and support around networking and looking at developing consortia in response to clients, to UKIMA and to the market. So spanning a whole range of digital areas, and that might be things like patient records, digital patient records, data modelling, and lots of other areas. Another one of our core and well-established special interest groups is infrastructure. This is a large group, and as you can see there, we do have a wide range of members there. In terms of their specialist offer, they work through the feasibility study. So we start with a client who maybe just has an idea or an ambition for change or for developing their healthcare facility. So we work with them in terms of the feasibility of that scheme. We'll offer legal advice. We have a firm of solicitors as one of our members. Finance, we work with a number of financiers and also UK Export Finance. So starting with that planning of the facility. In terms of the design, we have architects and looking at different models that we can develop. We have builders and equippers that can provide all of the facilities there. And then we commission and we can maintain those facilities. So it's the full life cycle from the initial idea through to operating the facility. In terms of our education training, this is one of our newer special interest groups. As I mentioned, we have universities, we have the NHS, and we have private sector education providers. We can offer access to learning platforms, and we've been working with some colleagues in the Middle East that wanted 100 different projects, 100 different education courses for their clinical teams, ranging from things like first aid and resuscitation through to very specialist training packages. So we work with Health Education England to make sure that we can offer that full range. So the education offer can be seen on this slide. We offer to the full multi-professional team, not just doctors or nurses, and including management and administration. And as you can see, our delivery methods, we can either do e-learning, online digital learning, face-to-face when we're permitted to travel, and blended learning. And as you can see, we run through workforce planning, establishing the workforce required within a facility or retraining of that workforce, looking at the clinical management training, the whole range, as you can see there. And it might just be that it's consultancy advice on how to establish education training programs. So we offer that full spectrum of support to our clients. In terms of consultancy, again, you'll see a large number of companies involved in the consultancy special interest group. And you can see the whole range, as I've mentioned there, in terms of what we can offer our clients. Hospital operations and management, we have fewer companies involved in this, but we can run facilities sometimes for 20, 25 years. We can support the client in securing the workforce required and ensuring that the standard operating procedures and protocols are established and evaluated. And the four key elements of this particular one is the scoping, again, working with the client around feasibility, planning, securing finances and the legal aspects, the commissioning of that facility, the operating of the facility, and then assuring the client of the effectiveness of that process. One thing, so we develop opportunities, or we secure opportunities for our members to offer their specialist expertise to international clients. And we do that in a number of ways. We scan world portals. We look at things like the World Bank, the Africa Development Bank, Islamic Development Bank. We look at these world portals to identify where there are opportunities for our members to bid for. We also work closely with the Department of International Trade, linking in with the embassies around the world, and we'll often hear about new developments that may be emerging that may be of interest to our members. But something that we are developing now is and some people may have heard of a hackathon approach. That's where we proactively approach key decision makers in different countries to proactively offer our support in resolving some of the challenges they may be facing. So it might be the development of services or enhancing existing services. So what we will do with clients is we'll work with them, we'll scope out the key challenges that they're facing in their healthcare services. We will hold workshops, creative solutions workshops with the client, where we will field a team that's particular and relevant to the challenge they're facing. And because we have such a wide membership base, we can field an appropriate team. And then we'll work with the client, identifying options, perhaps new solutions that they hadn't thought of, and then we'll provide a series of recommendations and options for them, with the opportunity to work with us in taking those forward. So this is a more proactive approach to offer our members services, and we're hoping to pilot this in a couple of countries, and we're linking in with the Department of International Trade colleagues at this point in time to explore that further. So in terms of what we offer, what UKIMA is, we're a membership trade organisation bringing together large-scale and small-scale commercial bodies with public and academic sector to provide integrated turnkey solutions to international clients. And we can be responsive and tailored no matter what the requirements are. We work very closely with a number of partners: UK Export Finance, Health Education England, Department of International Trade, Healthcare UK. And we're able to then work with those partners in offering those solutions to our clients. So in conclusion, what we do is we support clients in realising their ambition for excellence in the care they offer their patients. I have a background in the NHS and I have experience in international working from an NHS perspective, and I know that our international clients want to provide the very best care for their patients, and so we work with them, work alongside them, understanding their ambition and helping them realise that through the support that we can provide them. We have a number of very prestigious and worldwide known companies within UKIMA, and so we can bring together their expertise under our umbrella and offer that tailored solution to our clients' requirements. We also offer access to respected and trusted organisations, and our aim is to develop long-term partnerships rather than just short-term contract work, which clearly we can provide, but we hope that through the service that we offer our international clients and the partnerships that we bring to this, that we will develop long-term partnerships that are trusted under a UK company banner. And we have a number of case studies of work that we've done across the world, and you know, we'd be delighted to speak more about what we could offer you if you're interested in exploring this further. So that concludes my presentation. I want to thank you very much for inviting me to speak to you today, and I'd be delighted to take any questions that you may have. Thank you very much.
Amazing. Thank you so much, Jenny. Very interesting stuff. We've had a few questions come in, but as ever, if you do have any more that you think of while we're talking, please do submit them via that Q&A button over in the chat. So Jenny, lots to get through in the questions as well, so happy to have a bit of a chat with you about all of these in depth. So question number one is, what do you think the government could do to further enhance the UK's role in global healthcare systems?
I mean, that's a fantastic question, so thank you for that. The UK government is really promoting the UK expertise being offered internationally. We have the Department of International Trade, we have Healthcare UK, and a number of the other bodies I mentioned, like Health Education England and UK Export Finance, are passionate and committed to being able to harness the UK expertise and offer that internationally. We know we have prestigious academic bodies, we have the NHS with its specialist expertise, and we have commercial companies who are highly experienced in delivering successful projects abroad. And so I think through the Department of International Trade and Healthcare UK, we work very closely with them, linking with embassies around the world in raising the profile of our UK offer, and in attending things like trade fairs, global trade fairs. Arab Health is probably the most well known, but there are global trade fairs throughout the year, and the Department of International Trade and Healthcare UK have a presence at the majority of those and really are promoting UK on the world stage. So I think, you know, the government is passionate and committed to this. We're working closely with them, and I know that they're developing their own offers and aligning with ourselves. I think recognising the UK is often at the forefront of cutting edge technology and innovations in healthcare, that can also be promoted through those government channels. I know that there's going to be a new website called the UK Healthcare Pavilion, and that's bringing together partners from the Royal Colleges, and UKIMA will have a microsite on there, but all of those partners I've talked about. And this is really a window on the world through which we can then showcase all of our capability. And what we find is a lot of international clients trust, the UK, that we have vast experience. Our NHS has been around a long time and is credible and well respected. And so I think we have a fantastic offer for international clients. The government's recognised that, and they're really promoting this through those partners and attendance at global events and events like today as well, where we can showcase what we're capable of.
Absolutely, thank you. That's really helpful. All right, then question number 2 for you, Jenny, is what are the opportunities that come with the shift to digital of the UK's healthcare providers?
Well, that's another great question, because what we found, obviously, this big shift to digital working following the pandemic, we weren't quite sure how this would affect, because clearly we've not been able to go abroad and visit, and a lot of the time in our previous working, we would clearly get on a plane and go and visit a client and establish relationships there. So we weren't quite sure how this was all going to work. And I think for many of us a year or so ago, if people talked about Zoom and MS Teams, it was very, very little used. But we've found that through this rapid digitization, it's opened up a vast range of new opportunities for us. We've been able to link with clients much more easily, more accessibly. And certainly, I mean, I'm sat here in my kitchen in Manchester, and I've had conversations with people in Kazakhstan, in Abu Dhabi, in Dubai. I've had people from those countries speaking at our events, showcasing what they're doing. Our digital offer through our education training offer, we've been able to link with people in Saudi Arabia, all around the world, and we've been able to offer online access to that education training, which the client can access, night and day, whatever time suits them. So overcoming, time barriers, travel barriers, and a really effective use of our time, we've been able to jump on a call with Dubai, within a day's notice. So for us, this rapid digitization following the pandemic has really opened up new opportunities to us. It's made us more accessible, and we've developed some really fantastic relationships over the past year as a result of the ability to being able to communicate more effectively and quickly with our clients.
Absolutely, yeah. I think it's just been really incredible how rapidly we've managed to get used to this digital way of working. And like you say, the opportunities it's created are tremendous. So thank you. Next question then, and one that I'm sure you'll have lots to say on, is what are the benefits of becoming a UKIMA? Almost said it the wrong way then. UKIMA member as opposed to being on your own in the international market.
Okay, thank you. So being a UKIMA member, we're a membership trade organisation. People join, they pay an annual fee, and what we offer them is obviously networking. They will come into an organisation where they will bump up against and meet with people that they perhaps wouldn't have met before. All of our members have a passion for offering their expertise to international clients. If you're in UKIMA, you'll feature in one of our brochures that I showed. Each one of these brochures is a digital brochure that talks about the expert offer, that lists the members, and each member has their own section there and a link to their own website. and we showcase case studies. So if a member has done a piece of work internationally, that can be showcased in the brochure. And what that does, we're sending these brochures around to all the embassies around the world, to all of our partners that we have established worldwide. These brochures will be sent round. So you might be a small company in the UK offering quite a niche service. You'll feature in our brochure and you'll be seen around the world. So we really are passionate about marketing our members' offers, networking opportunities. We attend global fairs, particularly Arab Health. We have a physical presence at Arab Health every year, and our members can come and use our base. We can facilitate conversations with different clients. We have masterclasses every quarter. So we had one in April, which was focused on finance, legal and business issues. So our members can say they're struggling with this particular issue, or should you have MOUs or NDAs, and about the legal aspects. So we get those questions in and we put them to a panel of experts, and so they get free advice and support with any issues they're tackling. But in terms of opportunities, it might be that somebody sees an opportunity, but it's too big for them on their own. Well, what we do is we create a consortia around that opportunity. So it might be a bit of construction, bit of education, bit of digital, and we'll create consortia. We'll support that consortia to get to expression of interest stage. So we'll access the documentation, register the bid, we'll support that consortia being formed, and then potentially accessing finances through our colleagues, through our partners, particularly UK Export Finance. So you're not on your own. If you're struggling with an issue, you want to network, you want to access an opportunity that's too big for you, we will wrap around you and support you in taking that forward. And you know, everybody is of the same mind, and you're part of it's like a big team. So that's what we offer our members.
Fantastic, so many benefits there, thank you. Just sort of thinking back to the question before where we talked about the opportunities that come with digital of UK's healthcare providers, we have had a question come in and someone has asked, do you think there are any limitations though to the digitisation in the industry?
Well, I think, you know, we're very excited about the accessibility it's given us to get out to clients, but we do know culturally a lot of areas it's about personal relationships. It's about seeing people, you know, meeting them, developing that partnership, that relationship, and particularly if we're wanting to develop long-term relationships, digital communication has its limitations. So I think it's been fantastic in the situation that we were in and allowed us to continue and to diversify and expand. But I do think that there's nothing quite like meeting with somebody, you know, and developing that human relationship face to face. So I think maybe moving forwards, we might have a bit of both. This digital approach allows us to work effectively to move things on. But I don't think, as I said, it can ever replace those personal relationships. And certainly when we're able to, we will be flying out again and meeting with clients face to face. And just that sort of human bit about, you know, sort of chatting, and it's not so sort of intense, you know, there's more informality, I think, when you're meeting face to face with somebody. But I think a bit of blend of both is a good thing.
Yeah, absolutely. And like in terms of the limitations, I mean, you can never fully rely on the internet, can you? Especially as we've seen in the news the last couple of days, you never know what can go wrong. But yeah, I think a mix is the way forward for sure. Brilliant, thank you. And then someone's just asked a bit of a general question about whether, you know, how has COVID impacted you and the work that you've been doing over the last year and a half, short of all the travel stuff we've just been discussing?
Yeah, well, I mean, it's obviously been devastating around the world, but we developed an offer for the international market and we had a COVID task group that we set up, and we had about 20 different companies involved in that was able to offer our expertise to the international market. And that ranged from things like data modeling, if you're looking at surge planning, and post-surge, recovery, getting back to normal again. So we had data analysts. We've got people that provide specific mattresses that allow the patient to be turned. We had consultancy advice around recovery post-surge. So one of our NHS organisations had developed specific expertise in how, when you've had the surge as passed, how you start to then recover and get back to routine healthcare as well. So, I mean, I know that Britain had a challenging time in the COVID situation, and we understand that. But from that challenge, we learned a lot, and we have companies who were right at the forefront of managing those challenges, building the Nightingale hospitals or looking at the pop-up facilities that were required. So because we did get a great deal of experience, we can then offer that to other countries, that expertise to other countries in support of them, both within the initial surge, planning for any future surges in referral, but also how they get back on their feet again. And I think what the pandemic has shown is, in many areas, the lack of resilience in mainstream services. It might be capacity, and it might be workforce. And so what we want to do is we've got that expert offer that we can support different countries around the world in terms of the initial period, but also how they build up resilience and capacity in their healthcare systems moving forwards.
Brilliant. Thank you so much. We have a few minutes left, and so if anyone's got any last questions, do submit them now. But Ginny, I just thought I'd see if you have any other, comments or thoughts that you wanted to share with us before we finish.
Well, I just think I've mentioned the partners that we work with, and I think that's crucial, because we have our members and we bring together this integrated, tailored offer, but we couldn't do it without our partners. And we have in-country partners around the world, and we have obviously our UK-based partners, particularly DIT Healthcare UK and UK Export Finance. And I think it's that effective partnership working, which really makes the UK offer to the international market so compelling. And we're aligning with each other and supporting each other. And I think I hope that the international market will see that this is a trusted, reliable and integrated offer that they can work with. And clearly, if anybody was interested in just finding out a little bit more about us, we're going to be launching our refreshed website in the next couple of weeks. We've got our brochures and just an informal chat, just finding out a bit more about us and our members, because you'll see all of our members on our website. I'd be delighted to chat to anybody. My contact details are probably available through the conference organiser. So I'd be delighted to chat to anybody if you wanted to know more about our work, some case studies, or how you might get involved with us. Please do get in contact with me.
Yeah, brilliant. And you're easy to find on LinkedIn, because I had a little snoop earlier. And
yeah, we're very active on LinkedIn, and if you're become a new member, we do a big shout out to our new members on LinkedIn, and we'll tell people about you. We'll give you a week in the spotlight, and we'll link them to your sort of email addresses and websites. So we very much want to promote all of our members, particularly our new ones.
That's so good. LinkedIn is such a great platform, isn't it? I absolutely love it. Thank you. And I was just going to say, I bet you can't wait for the new website to launch, because I have been project manager of a few different website refreshes, and it takes so long, doesn't it? I bet you can't wait to see the new one.
It does. I mean, we've really refreshed a lot. We've refreshed our LinkedIn, our Twitter account, our website. And when you see it, and we'll make a big announcement, but you'll be able to navigate through. There'll be all of the brochures on there. There'll be all of our members, our partners. You'll see our case studies. We've got 12 different case studies from around the world. You'll see who was involved in that. You'll see pictures. So I think there's an awful lot on there that will be of interest to people. We've worked on it for some time, but it's hopefully is fresh and new. And we will also have a microsite to the UK Healthcare Pavilion site, which I would also recommend people visit, because that brings together a huge range of different organisations, all committed to supporting international working. So yeah, delighted with the website. We have our digital newsletter, which as a member, you might even be interviewed for our digital newsletter and have an interview with you on that. So it's exciting times for us. We're growing. We've grown in members recently, growing in numbers of partners and commercial opportunities. So it's just brilliant, and it's because we believe in what we offer, and we're very passionate. So yeah, be happy to chat to anybody.
Absolutely, sounds like a really exciting time for you all. So thank you so much for sharing with us. And unless you've got any final little bits, Jenny, I think that's it from us.
No, I just wanted to thank you very much for inviting me to speak to you today. I hope it's been interesting, and delighted to speak to anybody who wants to find out more.
Brilliant. Thank you so much, Jenny. I'm sure people will be in touch once they see that new website.
Thank you.
Amazing. Thank you so much, Jenny. Wow, that's it for today. What a fantastic day we've had once again as well. Thank you so much to all of our presenters and the team behind the scenes, and of course for you watching and taking part. An event really is nothing without some brilliant engaged attendees, so thank you so much. We can't wait to welcome you back tomorrow for our final day, and you'll very shortly see the agenda for tomorrow, so you can take a note, click on the event agenda on the left-hand side of the platform, and you can add in the sessions to your personal schedule that you would like to join in on. Have a great rest of your day, and we will see you tomorrow.